Hello, this is Lydia. Welcome to the session Validation of the PECUNIA tools conducted in Spain by the Spanish partners in the project, CESC and CICOST. First, we will talk about the validation of the unit costing templates in the Spanish context. Mencia from CICOST will tell us something about the external validation. Then we will report the validation in Spain of the value sets for the utilities developed by PECUNIA. And finally, Renata will tell us about a different validation approach by means of the application of the PECUNIA tools to a specific economic evaluation in Spain. Let's start with the validation of the unit costing templates. First, we have used the templates developed by PECUNIA to estimate the unit cost of services and consequences in Spain and in 4 Spanish regions. We have interviewed 4 people from different sectors and regions to know their opinion about the templates after trying them. The ultimate objective of all this was to analyze the feasibility and transferability of the templates. This table includes some of the unit costs we estimated for different regions and using the PECUNIA templates, and the services whose unit cost was not possible to estimate. For the Service 1 top-down microcosting, we only got partially completed templates because this template is too demanding in terms of data. Our contacts said that they did not have access to all data required in that template, time spent with patients, for example. Some sectors were more difficult than others. For example, it was not possible to estimate the unit cost for any services in the social care sector. One of the reasons was the unavailability of the relevant people in the sector because of the COVID-19 pandemic. Other reasons for no collaboration was lack of resources, lack of data, lack of access to data, and confidentiality, among others. Let us look at some cases. Case 1 is a special education estimated with Service 2 template. That is a top-down gross costing approach. The main provider of education in Spain is the public sector at the regional level. However, it was not possible to obtain data from any education body, only from the public mental health sector, as this provides part of the services given in the special education schools. For this reason, you can see in the image only cost of psychiatrists, psychologists, and nurses. So the unit cost in this case could be considered underestimated. Before going on with other cases, let's see some of the opinions we get from one of our contacts as a result of the qualitative study. The director of the costing program in the public health services in one region said that the Service 1 and the Service 2 templates are interesting and worth considering, but not enough to modify their methods. They have centralized data, but more aggregated. For instance, they do not need the actual working hours for their work. For this detailed data, they should ask all the primary care managements or even the health centers. Other 2 regions use the same reason to justify their lack of data related to primary care. This case is one example of the Service 2 short template that has been tested this year very successfully as we managed to estimate the unit cost of several services. You can see that this template is flexible and easy. Only total cost and number of contacts in 1 year are needed. The main problem here is that the description of the service and the list of costs included could be too vague or incomplete, as they are open fields to fill in, and this could make difficult the comparison across countries or regions. For example, we have estimated the cost of a contact with a psychiatrist in 2 regions in Spain, but we are not completely sure about what they are including. To be sure, we must go back to the regional sources. We had the opportunity to test the consequences template. We got a database with national data related to the reimbursements made by the national authority related to vehicle damages due to riots for the last 10 years. The only drawback is that riots are not the only type of car vandalism. In the image, you can see the costing template with the estimated unit cost for Spain in 2019. We were able to adapt the data collection template to our convenience because we just had a lot of data to play with. So the template and the methods suggested by PECUNIA allowed the estimation of several unit costs for several regions and several periods of time. The activity loss template was used as well. We found it quite easy and useful to have the data neatly compiled. Let's see one last case. We also use the personal time template to estimate the cost of the informal care. Our main concern here was to decide what 10 prices we should select to have a representative unit cost for the whole country, as there are 17 regions in Spain, and we identified at least 3 types of contracts. And now our assessment of the unit costing templates. Regarding the feasibility, for some services, it took quite some time and emails to reach the right person. We did not receive any answer from several bodies. Some bodies only provided secondary data, and it was not possible to get data from private companies. The time needed to understand and manage a template is short from the point of view of a health economist. However, the time depends on the number of data required and the number of sources that must be contacted to access the data. The data completeness also depends on the data. While some templates were not feasible, other templates could be completed just accessing published data or looking for market prices. And finally, regarding transferability, the structure and the content make the templates feasible in different jurisdictions. However, across countries, regions, we can find similar services with different names and different services with similar names. A clear, explicit definition of the service and the use of codes should be enough to avoid this issue. We find also services provided by several bodies within a sector or even by several sectors. The lack of integrated information systems and protocols for sharing data is a limitation for the estimation of unit costs. We find also different analytical accounting systems. PECUNIA templates could be seen as a burden, given the no perception of urgent need of comparison with other countries. This all can limit the estimation of a national unit cost for countries where the services are provided at the regional level. Some of these issues are beyond PECUNIA's control. And now, Mencia, please.
Good afternoon. My name is Mencia Ruiz, and I will be briefly presenting the focus group activity that was carried out as part of the external validation of the project. A focus group series were conducted with experts for external validation of methods and tools that were developed for evaluation of unit costs for the health, social, education, criminal justice, employment, and family patient informal care sectors. Participants in the sessions were 5 experts with background in economics and health economics, with specific knowledge in the regions assessed for validation: Catalonia, the Basque Country, Andalusia, and Canary Islands. The first day, the project and the PECUNIA framework were presented to the participants, and also specific information was provided on the validation activities and an explanation of the different tools for the evaluation of unit costs, like the service to short template or the costing template. On the second and third days, experts analyzed the services unit costs that were collected in the selected regions of Spain with the templates developed in the project. Analyzed services included health-related daycare, general practitioner, dental care, education services provided in a special education school for mental and non-mental health, car vandalism, and informal care. Loss of productivity was not addressed in these sessions as it was validated before in a previous focus group. Thank you very much.
Thank you, Mencia. Now we are going to present the validation of the PECUNIA value sets for the EQ5D in Spain. First of all, we selected some studies where the EQ5D questionnaire had been administered to Spanish populations. Then we applied the Eurocall group value sets for Spain. We also applied the new value sets developed by PECUNIA, the Pan-European value set and the supranational value set for the southern region of Europe. We conducted some analysis to compare the utilities obtained with both the Eurocall and the PECUNIA value sets. These were parametric and non-parametric tests and correlation and concordance coefficients. There is an ongoing external review by experts. These are the studies we have used to apply all the value sets. We have regional and national surveys with a cross-sectional design, and also longitudinal studies conducted in several regions in Spain. One of the cohorts included people with a diagnosis of depression attending any type of setting. Here we have some results. The mean utilities calculated with the pan-European value set or with the supranational value set for both the 3-level and the 5-level questionnaire are higher than those calculated with the Euroqual value set for Spain. In general, the correlation between the utilities calculated with the PECUNIA value sets and the Euroqual value sets is very high. The concordance between the Euroqual value set and the pan-European value set is, in general, substantial, while the concordance between the Euroqual value set and the supranational value set is perfect or almost perfect. However, in all the analysis we conducted, we found some exceptions to the general result. For example, the correlation is lower when patients reported minimal depressive symptoms based on the questionnaire PHQ-9. The concordance is lower also when we analyze the cohort of patients admitted to hospital because of heart failure. According to one of the experts we have talked to, the longitudinal data are more relevant to validate the value sets than the cross-sectional data, because it is the changes in utilities or differences between health states that would have an effect in the incremental QALYs and consequently the ICER, that is the ultimate result of the cost-effectiveness analysis. So now I will give the floor to Renata, who is going to go on with this topic. Renata, please.
Thank you, Lydia. So the second part of our task was to take all the methods developed in PECUNIA and use it in a real-world health technology assessment, for which we use the abbreviation of HTA. Each HTA project consists of several phases. We perform systematic reviews of literature regarding effectiveness, safety, and cost-effectiveness of the evaluated technology, and also an economic evaluation where we can compare costs and benefits for a given context. In PECUNIA, it was decided among all project members at the beginning that the scope of our assessment would be the stepped care model for depression. Stepped care is defined as a hierarchy of interventions from the least to the most intensive, meaning that the most effective yet least resource-intensive treatment is offered to the patient first, and it can be also adapted to personal needs. This approach is broadly recommended worldwide, especially in mental health, and in Spain specifically, there are clinical guidelines based on the recommendations of NICE. So in the first step of the assessment, we searched the scientific evidence on the effectiveness, safety, and cost-effectiveness of the stepped care model for patients with depression of any level. This intervention was compared either with other treatment model or with the usual care. As a result, we identified and analyzed 18 effectiveness studies and 8 cost-effectiveness evaluations. We could conclude that the stepped care model seems to be more effective in patients with higher severity of depression, and regarding its cost-effectiveness, it seems to be cost-effective when used for prevention of depression. However, for the treatment, the results were not so clear, meaning that some studies concluded in favor and some against the stepped care, depending on the country, perspective of the evaluation, and the content of the intervention. The next phase of the HTA project was the economic evaluation for the Spanish context. We constructed a decision tree model which takes into account the depression and remission states in different points of time, namely at 3, 6, 12, and 36 months. The data needed to construct this model were taken from a randomized control trial in primary care settings in Spain. So, for example, this study provided us with information of how probable it is that a patient treated with stepped care will have a remission at 6 months, and how many times will he or she visit a general practitioner, nurse, or specialists in healthcare in that period. The PECUNIA methods were applied in 2 levels. On the one hand, to calculate the unit costs of resources needed for the treatment. These resources included visits to general practitioner, nurse, or mental health specialist, but also productivity losses due to the illness, and the time spent in caring for the patient by a non-paid caregiver, such as a family member, for example. The unit costs of all these resources were calculated using PECUNIA templates, and they were compared to the methods that we usually use in HTA projects, such as mean values of regional tariffs or literature search. On the other hand, the PECUNIA methods were used to calculate the benefits in terms of utilities, applying the pan-European and supranational value sets developed during the project. Here again, they were compared to the usual method, in this case, the value set for Spain. And here we can observe the differences between the unit costs calculated with PECUNIA templates and those calculated with our usual method. The PECUNIA methods were used at national level and also at regional level, namely for the regions of Canary Islands and Basque Country. We could observe some important differences between regions and between methods. And in this table, we can see the utilities for different stages of depression and calculated with 3 different value sets. The primary data came from an observational longitudinal study of more than 400 patients with depression in Spain. And we could confirm the conclusions of previous analysis, that is, that the pan-European value set produces the highest values of utilities compared to the supranational and national value sets. So the final objective of our analysis is to see how these differences in costs and utilities will impact the cost-effectiveness ratio of the stepped care. For example, if one method results in better cost effectiveness than the other. This work is now in progress and the results will be presented in our final report. Thank you very much for your attention and don't hesitate to contact us for any doubt.